Good morning everyone. I am Dr. Monica Gupta. Today we are going to discuss about how to differentiate between PCOD and hypothyroidism in adolescents. As the symptoms are overlapping, so it is a challenge for us how to diagnose because the symptoms like irregular periods, weight gain and fatigue are common in both. However, if we have a systemic approach based on clinical features, laboratory tests and imaging, we can distinguish two conditions. Clinical features are in PCOD, menstrual irregularities like oligomenorrhea, amenorrhea or irregular cycle due to chronic anovulation are common, whereas in hypothyroidism, amenorrhea, menorrhagia or oligomenorrhea due to hormonal imbalance occur. In PCOS, weight gain is mainly central, that is abdominal obesity, and whereas in hypothyroidism, diffuse weight gain with a slower metabolism is there. In PCOD, skin changes are acne, hirsutism, and androgenic alopecia due to hyperandrogenism, whereas in hypothyroidism, dry skin, coarse hair, and hair thinning is common. Energy level in PCOD is normal or slightly reduced, whereas in hypothyroidism, fatigue and lethargy are common. In PCOD, symptoms due to hyperandrogenism like excess body or facial hair are there, whereas in hypothyroidism, symptoms like cold intolerance, hoarseness of voice or constipation are common. When we perform laboratory test, TSH is usually normal in PCOD, whereas in hypothyroidism it is elevated in primary hypothyroidism or low in secondary hypothyroidism. Free T3 and T4 are normal in PCOD, whereas they are low in hypothyroidism. FSH and LH ratio, it is elevated in PCOD, whereas it is normal or altered in hypothyroidism. Androgen levels are elevated in PCOD. There is an elevated testosterone, DHEAS, whereas they are normal in hypothyroidism. Prolactin is normal or mildly enlarged in PCOD, whereas it is elevated in hypothyroidism due to stimulation by TRH. Lipid profile, it is may show dyslipidemia in PCOD, whereas there is a elevated LDL, triglyceride and total cholesterol in hypothyroidism. In PCOD, hyperinsulinemia or insulin resistance is seen, whereas in hypothyroidism, mild insulin resistance can occur. When we do ultrasound in PCOD, pelvic ultrasound shows enlarged ovaries with multiple peripheral cysts like a string of pearl appearance, which is a classical features, whereas the ovaries are normal in hypothyroid patient. When we are doing thyroid ultrasound in PCOD, thyroid appearance is normal, but in hypothyroid patient may show thyroid gland enlargement or nodules in gland. Our diagnostic focus is PCOD is primarily a diagnosis of exclusion, relying on Rotterdam criteria. At least 2 out of 3 should be present. It is oligomenorrhea or anovulation, clinical or biochemical hypoandrogenism, polycystic ovaries on ultrasound. In hypothyroidism, diagnosis depends on elevated TSH level with low T3 or T4 level, clinical signs showing hypothyroid deficiency, positive thyroid autoantibodies like anti-TPO or anti-thyroglobulin in autoimmune thyroiditis. Key differentiation points are in hyperandrogenism, PCOD, acne, hirsutism and elevated testosterone are hallmark feature of PCOS which are not present in hypothyroidism. Systemic symptoms like cold intolerance, constipation, generalized fatigue are more common in hypothyroidism. Ultrasound finding of polycystic ovaries are in favor of PCOS, whereas thyroid abnormalities are suggestive of hypothyroidism. In last, we conclude by saying that perform TSH and free T4 level in all adolescents with menstrual irregularities to rule out hypothyroidism before diagnosing PCOS, and for PCOS focus on androgen level, LH-FSH ratio and ultrasound finding. If both conditions coexist, treat hypothyroidism first or correct it it can improve menstrual irregularities and other overlapping symptoms. Thank you very much.